So when you look at these three kind of deformities, you know that you have to have a different strategy. You also know that you have to have a different technique. You also know that you have to have different kind of implants and instruments ready. So this is supposed to be a talk on surgical steps and video presentation. So I'll go through the steps on a slide-based show because that makes more sense than showing a running video. So these are the three different type of curves. So we totally have a different mindset when we start this, like the previous speaker mentioned. So just recap of principles, it has to have good pre-op planning. But exactly what do you pre-op planning? Knowing your levels and your correction strategy and your bending levels correct. This is a very important point. You have to have generous soft tissue and bony release. If you try to go and pull and push on a rigid curve with nothing released, your implant is going to fail. So you have to take up a good release. We'll see it. What is it? And you have to have strong anchors in the strategic vertebrae. We heard Dr. Shankaracharya's talk where he spoke about all the strategic vertebrae and how to decide the levels. And show really strong anchors. If your screws are not holding well, you cannot expect any great correction. You have to use the appropriate maneuver, like the previous speaker who gave an excellent presentation of all the techniques of correction and with all the equipment. And this is very important. We heard Dr. Arvind Kulkarni say at the outset that balance is everything. He spoke about cone of balance and all that. So you have to try and achieve the balance and make sure that whatever we do, you end up with a fusion. So each part of this process is very important. If you do a good correction, don't fuse well, you end up with a pseudoarthrosis. So that is not welcome. Now, this is a very, very important point when you come to adult or adolescent deformity correction. This part, the most important part is not the fused area, but how the unfused area behaves with respect to fused area. Meaning, look at the middle part. You have a harmonious curve correction. Your lumbar spine compensates. Look at the last part of the image. You have a straight fused spine. So your lumbar spine ends up straight and that ends up with a poor outcome. So today we know that one single thing which matters in the long-term outcome of deformity surgery is sagittal plane. So HRQLs totally depend upon your sagittal plane correction, not your coronal plane correction. So this should be kept in mind whenever you plan any kind of correction strategies. So the three things which I will not go again. So first thing, when I start the surgery, pre-op is to make sure that I explain the wake up to my patient because my neuromonitoring can fail. So every patient, I tell that you have to have, we might wake you up and tell them how to do the wake up test. Second, make sure I got adequate PRBCs ready. I have to have the patient's photographs and consent checked up. I also have the surgical plan with my screw strategy printed in the paper and stuck to the IV stand, which I look up frequently. And before posting, I make sure I have the baseline MEP SSCP, have a catheter inside. I always use tranexamic acid at the dose of 30 mg per kg in adults and 20 mg per kg in children, which is an infusion followed by 10 mg per kg infusion throughout the surgery. This has decreased my blood loss significantly. I hardly end up giving 1 unit of transfusion in a D2 to L2 curve. Use antibiotic prior to insulin, all standard protocols. And we have this IONM checklist stuck in the theater. So what to do when we have an alert in the neuromonitoring, which is available in the website. I will not go to the details of that. When I post-intimation, I use a Wilson frame or a Jackson frame, both of them. Make sure that the bony prominence are padded very well. Make sure that the eye is padded very well because that's very important. And always get an IONM, your MEP levels done after you prone the precision, especially in a neuromuscular curve. You might lose signals when you have this, or your baseline might change, so I have to get it done. Then is the incision. You can use a straight incision or curved incision. I use a straight incision. I get standard exposure. In a pediatric patient, I split the epiphysis with a knife so that I get real subperiosteal elevation. You have to have tip-to-tip exposure, that is, tip of the transverse to the tip of the transverse process, and keep the map around 60 to 70 to make sure that you don't lose much of blood when you expose. Pack it up all pretty much regular. This point requires care. At the upper level, you don't want any PJK or a proximal kyphosis, all the more relevant in adult scoliosis than adolescent scoliosis. So I try and keep all the supra and interspinous ligaments intact at the top two segments, and I also don't do a Pontes or a facetectomy at that levels. I preserve the facet capsule with a lot of care, because this is the only thing which we can do with respect to soft tissue preservance in a AIS to prevent the PJK. And always make sure you adequately expose at the, especially at the upper level, because you are going in, when you have to go to a D2, your upper curve is in kyphosis. So you tend to really, you have to bend your instrument to get your trajectory correct. There, don't pull and push, do a liberal skin incision, and don't damage the capsule and the suprainterspinous to get your screw inside. It's a very important point to avoid retraction. If not, they'll end up with a dirty scar there, because the neckline, most of them are females. So the neck, around the dress, you will see a bad scar there with a beautiful scar in the midline. So that's very important. You would take care of that. Once I expose everything, I put one screw. I, as a matter of fact, always try to put the screw at the D12 if it is a thoracolumbar curve, if I have to go, because from there, there are many people who ridicule using a C-arm in scoliosis. After I put my screw freehand, I make a AP shoot and count my levels from there. So it's counted, checked by two people, me, my assistant, and the nurse. So we all make sure that my screw is correct, so that I don't miss anything. I have missed it earlier. So that is a check which we do. Then we go ahead. Next, after exposure is released, nothing goes inside, no implant goes inside until I release properly. So this should be followed methodically. It's been different classifications, whatever you do. For me, that I do a facetectomy first. I remove the inferior facet. I use an osteotome. If you have a Mesonics like the previous speaker, so it's very good, decreases blood loss. I don't have a Mesonics, so I use an osteotome that gives me enough bone to form a fusion. So do an inferior facetectomy that will expose my facet, the so-called Mohs osteotomy, and make my entry point clear. And in places where I plan to do a posterior column release, I do a Pontes. A Pontes is nothing but an extended kind of facetectomy with suprainterspinous release. I do a Pontes. And remember, when I do a Pontes, I'm expected for blood loss. That is a place where I will go inside the canal. So I keep things ready for the bleeding to be controlled. Now, this is exactly what I remove in a case of posterior column osteotomy. What do you call it, Pontes or PCO or whatever? So once that is one of the pros of using a Pontes is that you kind of lengthen or shorten. The posterior column is under your control. It bleeds a bit more than your normal inferior facetectomy, but I get better correction of my thoracic kyphosis, and I get better correction of my lumbar lordosis, because I'm going to shorten the lumbar column and lengthen the thoracic column. It's more easier when you do a Pontes. So conceptually, after you've done a Pontes, the only thing holding the vertebra together is the annulus in the front. The rest all you release, the costotransverse joint, you release the facet joint, supraspinous. Today with the liberal Pontes, I hardly have to do any kind of osteotomies and on the discal level to get your column corrected in an AIS case, which is not a pleasant thing to do because they bleed a lot and got more complication rate. So then you can choose whichever strategy you chose for your screw insertion. Once I have got my things released, I basically go into a strategic vertebra. I try to have two screws in every strategic vertebra, which kinds of comes at your screw density around 1.5. That is your choice, whatever thing you are trained in, you're comfortable. But this should be very sure. All the strategic vertebrae, wherein the apical, the UIV, the LIV, and all the peri-apical, concave, and convex should have screws inside, because that helps you in do your direct vertebral rotation or whatever. In this, my primary maneuver of choice of doing scoliosis AIS correction is translation, sagittal as well as coronal. I don't use rod rotation for rigid curves. Rod rotation is used only for very, very flexible curves, even though I trained classically doing a rod rotation. So I do a sequential reduction using the towers or whatever thing that particular equipment starts. So that is done by rod. I try and always use a Cobolcombe rod, because that is bent high. The concave rod is bent more than the convex rod, because my concave is the pulling side and my convex is my pushing side. I repeat, my concave is the pulling side, convex is the pushing side for a thoracic curve. So it is started. I start the engagement from one of the ends and gradually keep going towards the center and come down. And all these equipments help me do it sequentially. Whenever I do, you can see this. One of the assistant holds the rod. It is locked onto the screw. Plus, one of the assistants holds with a rod grip, because the rod should not rotate when you try to pull it up. And you gradually get the screw one by one into the rod. Basically, you get the curve into the rod. In a very rigid curve, you can see that at some point of time, the rod starts going down into the curve. So this is how you do. You gradually cantilever them one by one. You get them reduced into the rod, and then after I've done my rod reduction, then I always do direct vertebral rotation. I hardly do a costectomy or a costoplasty today for an adolescent curve after I learned how to do a DVR properly. Doing a DVR properly is a technique which you have to learn. When I do a DVR, we have four people. We have four people who have to do a DVR. Number one, the rod is locked inside. It's inside the captures. The lowest end is tightened. You should keep the upper end free, because if not, it will not be able to derotate. Two rod grippers go on the rod. I then this picture, which is classically the Medtronic picture when it was described, I use rod grippers, two of them, and one assistant holds both the rod together. Second guy puts in the towers inside like this, and with the cross connection connected. The third guy gives a push on the rib hump so that my corrective force is dispersed between the implant and the physical push. And the fourth guy tightens the screw. I repeat, one person holds both these rod holders together and holds it to the foundation. The second person does the towers with the cross connected and rotate it. Third person pushes on the rib hump. Fourth person tightens the screw. So this sequence we follow at each level. You start at the edges and go to the center. Why? Because the center or the apex is the most rotated vertebra, or the end or the edge is the least rotated vertebra. We are doing rod direct vertebral rotation. So we go from the least rotated to the most rotated. So I don't do an en-bloc VCM because I feel that's too much stress on the implant. So I do from the edge gradually. As you come to the center, you find that the apex is quite a lot derotated, and that helps you less stress on your screws. So once that is done, you make sure that all your captures are tightened very well. Or these are the things which I mentioned. If I use a hyper concave rod on the concave side, or a hypo concave bend rod on the convex side, to make sure that I get my vertebral derotation corrected. Because whatever you do in scoliosis, whatever maneuver you follow, you are trying to do a transverse plane correction. You are trying to derotate the vertebra. So this is the way how it is done. Once that is done, I look at my shoulder balance. I make sure that the shoulder balance and the caudal balance is done. I use the cautery, cortex, whatever thing you're comfortable with. I make sure that my shoulder is balanced. I take a C-arm shoot at this stage, see that my caudal disc is parallel, my shoulder, my cephalic disc is parallel. This leads to a big can of worms. Does upper UIV equal to shoulder balance? It is not a debate for this session. So I try to match my LIV to UIV parallelism. And then at this point, if I'm tired, I take a break. Why? Because the real surgery starts now. If I don't do a meticulous fusion, my surgery fails. So by this time, if I'm tired, I take a break, have coffee, come back, and then do the decortication, do the fusion, and then do a closure. So this, remember, whatever you do inside the spine, if you give a dirty scar, more so in a female patient, they will curse you for life. The patient doesn't look at all these things, they look at the scar here. So this should be done very meticulously with patients. So that's where you need to take a break or have somebody else close for you who does a good job to look at the upper end of this. Too much of retraction leads to a sore there, and that leads to a bar scar and a keloid. Couple of cases, these ones where you see large rigid ones hardly doing anything, any action on the bending X-rays. You do them. We do a kind of Fontes, and can see Fontes at every level. One of our earlier patients, 2009. So go, and this is where we had got a significant correction without doing any column osteotomy. This is it. And remember this, prerequisite for a successful correction maneuver in AIS is adequate release. Again, repeat, adequate release, strong anchors, and a solid fusion. This should be hammered into our minds each time that this is the way it should go. Another patient, these kind of large curves when you know that your classical thing of rotation extra will not work here. So this look at the CT of this patient had hardly anything on the convex chest. So we went ahead, we gave pre-op halo traction, halo traction, and then went ahead and did an osteotomy. A posterior colostomy did not touch her chest. I didn't want to touch her chest with this. If I do a thoracotomy, that's an end for her. And this is how we got it corrected. And this is how she was immediately post-op on day 10. Another, like the previous speaker showed, when you have this kind of curve, elderly, female, they come with pain more than the deformity, normal neuro. If you look at it, significant harm. So this is not a classical AIs. These are the ones who had some component of congenital which grow into adult and end up with a significant coronal and sagittal imbalance. You know that whatever you do, unless you release the bony column, you will not get a correction in these patients. So there we went ahead, we went and did a 3-level vertebral column resection in this. And you look at this is a classical way when you look at the 2 or 3 level VCR done for a scoliosis. The C-arm or the X look very ugly. The cage look out of plane because you have corrected the deformity. It's a multi-apical deformity. And this is how the finding of the child is. You get about significant amount of correction in these patients. So to conclude, you have to have meticulous planning, judicious use of anterior, posterior, or anterior and posterior releases. Often needs combination of many maneuvers. You cannot succumb or say that I only use translation. You have to mix all your maneuvers, compression, distraction, everything. You have to resort to sometimes to complex instrument strategies, dual rod, triple rod, etc. And when you deal with this, a complex nerve curve needs complex techniques. So when I believe this is primarily focused on the residents or starting surgeons in spine surgery with deformities. So choose your case very well. Don't start a case unless you discuss, get into one of those forums or get help, discuss your cases, because the level you think might be different from the level somebody else thinks who's more doing it regularly. So get help, plan everything, and get him to stop with you for a couple of cases. Then start your own, because the most sad thing is to come out of a deformity with a complicated, because like what Dr. Vishal Kunani mentioned, deformity surgery is one of the most rewarding surgery in spine surgery. Thank you for your patient listening.